Thank you for joining us today. My name is Dr. Chris Conley. Today we're going to discuss the pathophysiology of persistent post-concussive symptoms, also known as post-concussive syndrome or continued disorders due to traumatic brain injury. And so we're going to stay in this middle category here, PCS, persistent post-concussive symptoms, but it's also important to realize, and we're going to go over a little bit about the initial stages of TBI and the progressive stages of neurodegenerative disorders. So we have a lot of information to cover, so let's get to it. Brain injury is a major problem around the world, but in the United States, 1 in 60 people are living with a permanent brain injury-related disability. That number is huge, and I think it's underestimated. I think the real number is close to 3 in 60 people. And this is also a problem because the acquired brain injury has been labeled as a silent epidemic. So the neurodegenerative changes that we see over a patient's lifetime can lead into dementia, seizures, stroke, other problems that may not be related. So the Brain Injury Association of America says it's 1 in 60 people are living with a permanent injury-related disability, but that number may be higher. The Brain Injury Association of America has a textbook, The Essentials of Brain Injury Guide. I'd recommend anyone to get that. But this was a paradigm shift for me when I read this and started thinking about it is TBI is not an event or a final outcome. Rather, it is a beginning of a chronic process. This is important to repeat. Traumatic brain injury is not an event or a final outcome. Rather, it is the beginning of a chronic process. This is a huge paradigm shift, not in just patients, but also treating patients and also looking at the big picture of traumatic brain injury. I'll often get in and do some impairment ratings or have been teaching classes in impairment rating. And the impairment guides also realize this as well. Talking about diseases such as brain injury is that one can usually anticipate the future decline based on the natural history of the disease process, which is generally well established in the literature. So this is very important to realize that the pathophysiology of it is essential to understand and learn to be able to develop treatment protocols to be able to reduce the long-term neurodegenerative effects. So today we're going to go over the pathophysiology, and it is important to realize that understanding the pathophysiology gives a better understanding of what the treatment should be to reduce the long-term chronic nature of these pathologies. This paper builds off of the previous slide. Traumatic brain injury, a disease process, not an event. Broken brain does not equal a broken bone. This is really essential to start understanding the fact that our bones, if they break, they have a process to heal. Our brain, injury to the brain is a functional injury that sets off the process of secondary changes in the brain. So it's a completely different injury. But a summary from this article states that the purpose of this article is to encourage the classification of traumatic brain injury as the beginning of an ongoing, perhaps lifelong process that impacts multiple organ systems and may be disease causative or accelerative. Traumatic brain injury should be managed as a chronic disease and defined as such by healthcare and insurance providers. It's been said that the human brain is the most complex structure in the universe, and I would agree. It is involved in virtually every process in the body. And when you think about what the brain actually does and dive in deep on a cellular level, what happens in the brain, it truly is astounding. But we also have to realize that a brain injury is the most complicated injury in the universe. And that's an important thing to understand because there's not one brain injury that's alike. Everything is actually, every person is different. Every brain injury is different. So it's almost like a snowflake. Every brain injury is going to present a little differently, and there's various reasons for that. But the brain is 3 pounds. It processes over 70,000 thoughts each day, using over 100 billion neurons that connect more than 500 trillion points through synapses that travel 300 miles an hour. Each neuron can transmit over 1,000 nerve impulses per second, making tens of thousands of connections with other neurons. This is truly astounding, and it controls most aspects of the body and things that we don't even know that we don't know that we don't know. So the brain is truly an amazing structure. An injury to a brain injury is very complex. This builds off the previous slide. The brain is truly amazing and complex, and there's a lot that we don't know that we don't even know that we don't know. But this was a cool study that was done last year. We know that there's about 100 billion neurons or brain cells, but before last year, they thought that we had about 300 different cell types. A study last year came with an amazing fact that we have over 3,300 different cell types. And they don't even know what a lot of these different cells do. So this is 10 times what they thought as far as the number of cell types. This is truly astonishing. Now, we do know in general we have about 10 times more glial cells, so almost 1 trillion glial cells in the brain. These glial cells, like the oligodendrocytes, astrocytes, microglial cells, and epithelial cells, help the brain to function better. Damage to these cells will ultimately damage the neurons. So we focus a lot on the neurons, but we have to realize these support cells, the glial cells, hold the key to a lot of the functional things that go wrong in the neural cells. So think about the oligodendrocytes. One oligodendrocyte is for one nerve, and the whole purpose is to coat the nerve with myelin sheath to help with the conductivity. Think about on a wire. You have conductive wrapping that goes around the wire to help the nerve to fire better, or help the wire to fire better, the conductivity to make the signal better. If the oligodendrocytes aren't functioning well, what's going to happen to that neuron? You're going to have decreased conductivity. The astrocytes, they're like sort of like the moms of the nerves. They help to protect it, nourish it, feed it, take care of it. Damage to that can cause problems with the nerve where it starts to deteriorate. The microglial cells, they go around and help to clean up things. So if they're not functioning well, you're going to have debris. You're going to have toxins that develop in the brain. And the epithelial cells, they help with the blood-brain barrier. So if you have a problem with those, that's going to cause toxins to leak in through the blood-brain barrier. This is an important thing to realize, one, how complicated it is, but each tissue type, and there's some tissues we don't even know what they do, but the dysfunction in those can have wide stem longing effects because of the fact that damage to these glial cells can have an influence on the brain long term. As I stated earlier, each neuron forms connections with other neurons, which could add up to 1 trillion or 100,000 trillion connections. There are more synapses, nerve connections, in your brain than there are stars in the galaxy. This is an example on a microscopic level what they're looking at. It's truly amazing. The brain is one of the most metabolically active organs in the body. Despite not performing any mechanical work like skeletal muscles or the heart, in terms of energy metabolism, the brain represents only 2% of the total body weight, but is responsible for 20% of the global oxygen consumption and 25% of the glucose consumption, and moreover receives about 15 to 20% of the cardiac output under resting conditions. So the brain is one of the most metabolically active things. It's a central processing unit for the entire body. And there's a lot of things that really need homeostasis, need to have a balance. And blood flow is one of the most important things that we're looking at today because too much or little blood flow dysregulation, can cause havoc within the brain. It's been shown that after a brain injury, the blood flow to the brain can reduce by up to 50%. This is essential because of the fact when you reduce blood flow to the brain or reduce metabolic activity, what is a patient going to feel? They're going to feel fatigue. They're going to feel overwhelmed. There's a lot of things that neurophysiologically will happen because of the reduced blood flow to the brain. This is essential to realize that the brain is responsible for over 20% of the oxygen consumption, 25% of the glucose consumption, and about 20% of the cardiac output goes to the brain. Many times with a brain injury, we just focus on consciousness, we focus on memory, but brain injury is a lot more in depth than that, a lot more complicated, a lot more far reaching. Brain injury and body systems. The brain controls virtually everything in the body. So you'd expect also to see that when you have a brain injury, you could have cardiopulmonary or vascular problems, musculoskeletal problems, elimination problems, gastrointestinal, metabolic and endocrine problems, reproductive problems, problems with the skin, problems with infection, sleep, and neurological problems. Yes, there's a lot going on in the brain. We could look for the neurological symptoms, such as dementia or memory problems or other neurocognitive aspects of it. But brain injury is a far-reaching injury. Like the CPU of your computer. When that goes haywire, that could affect other things. Now, to understand more about PPCS, it's really essential to dive into the secondary brain injury. What is a secondary brain injury? Well, we have a primary injury, which is the mechanical insult to the brain, and then we have a delayed injury. So that's called the secondary injury. So, secondary brain injury is a series of changes that can occur in the brain hours to days after the initial injury or primary brain injury. These changes can be cellular, chemical, tissue, blood flow related, and can lead to further damage in the brain tissue. So, we're going to go over this in a lot more detail, but this is an important thing to conceptually realize as well as the primary injury, the initial trauma stage, and the secondary functional effects that occur in the brain. And this is what we really want to focus on this second stage of injury, which is the PPCS, is the fact that the continued symptoms are due to functional changes in the way the brain is working and functions around it on a cellular level, chemical level, tissue level, and blood vessel related. So this is a very complex thing that we're going to dive in deeper, but even at the beginning stage right now, we want to focus on the primary injury and the secondary injury. This is a great paper if anyone wants to dive in deeper to the pathophysiology of mild traumatic brain injury. This is a great paper to read more about that. But one quote which was really important that I thought I wanted to point out was because these mechanisms of secondary injury manifest later, they can be prevented or treatable. And I think this is the key to neurodegenerative diseases in the brain, to treatment of brain injury, is realizing these second injuries and reduce the likelihood of developing the secondary injuries. And so this is a great paper that talks about that because of the fact that understanding the pathology can help to provide better treatment or even access to treatment. About 50% of people with brain injury don't get diagnosed. The other 50% don't have access to care. So it's important early diagnosis and getting patients the care they need in a timely manner is essential to reduce the long-term neurodegenerative changes that we're seeing in our society as an epidemic. Many times with traumatic brain injury, we're focused mostly on the symptoms and, what are the symptoms of brain injury? And we're focusing on what are the symptoms. This is a paper of cardiac function that showed that there's a degree of physiological variability may persist after the symptoms resolve. And again, conceptually, this is important to realize that we focus on the symptoms, but the functional changes in the brain may remain. Sure, when the symptoms resolve or get better, that is a great prognosis outcome or better prognosis outcome. But we have to realize that the physiology of things occurring in the brain are different than the symptom resolution. And we have to focus on complete brain healing or function restoration rather than just the symptoms. Now, we discussed a little bit about trying to reduce the secondary effect of brain injury. But this was a study talking about what happens on a cellular level to the microglial cells. And the outcome of the study basically showed to date there are no treatment was proven to be effective for reducing white matter damage or stimulating white matter remyelination after a brain injury. So again, conceptually, we want to say, okay, physiologically, what's going on? What do we do to correct the secondary pathology? But the studies have shown there's really not much that have been proven. I think in the future, you're going to see laser therapy, nutritional therapy, exercise therapy. There's a lot of technologies and therapies that will start being used in the coming years to focus on changing the pathophysiology or normalizing the pathophysiology from inside, not just from outside. And when you restore the homeostasis within the body has a better chance of recovery. So although in theory we want to reduce the secondary aspects of brain injury, to date there's no treatment that's been proven to be effective for reducing white matter damage or stimulating white matter remyelination after TBI. This is an interesting study of 1,689 people who had brain injury without loss of consciousness and later in life had autopsies, and they found that Even without loss of consciousness, brain injury was associated with higher odds of neurodegenerative and vascular pathological findings later in life. And again, this falls into the framework of the progressive neurodegenerative and vascular changes that occur subclinically sometimes in patients' lives. Again, another paradigm shift for treating patients with concussion is recovery from a clinical standpoint is different from a physiological standpoint. Currently, there's no medications FDA approved to treat traumatic brain injury. Sure, there's medications to treat the symptoms, but there's no FDA approved medications to actually treat the brain. And so clinical recovery is different from a physiological recovery. One of these slides is from the Complete Concussion Management Training course. I'd recommend anyone who wants to know more about concussion or how to treat it. Complete Concussion Management is a great group to dive deeper into the best methodologies to treat patients with concussion. But clinical recovery and functional recovery are both ways to measure recovery after brain injury that have different focuses. Clinical recovery focuses on the acute care phase of traumatic brain injury and aims to sustain life and minimize further damage to the brain. Clinical recovery also focuses on symptom resolution. Functional recovery focuses on post-acute phase of TBI care and aims to improve the patient's day-to-day function, normalize homeostasis, and the ability to live in community. Functional recovery is an evidence-based approach that helps to improve patients' overall health and quality of life beyond symptom management. And these are two important aspects for brain injury, but important to realize that they are different. So clinical recovery, mostly based on the symptoms. Functional recovery is to restore homeostasis, improve the quality of life. And these are really both essential in the treatment of patients with brain injury. But when it comes to it, it's really important to realize that recovery from a clinical standpoint is different than a recovery from a physiological standpoint. Secondary brain injury is a series of changes that occur in the brain hours to days after initial or primary brain injury. These changes can be cellular, chemical, tissue, or blood vessel related and can lead to further damage to brain tissue. This is a diagram that goes over the primary injury causing brain damage. If there is physiological, neurological, and metabolic recovery, we see symptom reduction and normal physiological response in the brain for healing. So we have normal healing, and we typically would see recovery. If after the brain damage, we see a cascade of secondary changes causing secondary damage or tissue damage, causing secondary symptoms, disease, and dysfunction within the brain or the entire body for that matter, we see a residual cycle of brain injury, brain damage, cascading events, and this could be a problem that leads to the secondary injury stage. So this is only an hour presentation, but as you can see, there's lots of secondary effects that occur in the brain that lead to the pathophysiology of the secondary injury. Each one of these topics could be an hour alone on discussing neuroplasticity and cell death, some of the pathophysiology that goes on into the brain. But we're going to do an overview of these that, a secondary injury is an injury that results as a result of another injury or consequence of changes caused by the primary injury. So with brain injury, and these are things that we have known, but there's a lot that we don't even know that we don't know that are occurring. But these are very much known and scientifically proven changes that occur in the brain that lead to pathophysiology of the secondary injury. Negative neuroplasticity. Neuroplasticity, I think, is huge in the recovery aspect of brain injury. And negative neuroplasticity is very much responsible for a lot of the changes we see that lead into secondary injury. Blood flow dysregulation, myoglial cell dysfunction, cellular senescence, or so-called zombie cells. Cells basically become inactive. They also secrete things that kill cells around it, but these zombie cells are very destructive for the brain. Mitochondrial dysfunction. I think this is a huge area that science is showing is essential that cause secondary injury, but also laser therapy, exercise therapy. There's a lot of things to do to help the mitochondria to function better. But mitochondrial dysfunction is a major pathophysiology effect. Metabolic changes and ROS dysfunction, again, huge. Cell death, blood-brain barrier dysfunction, decreased neurogenesis, neuroinflammation, again, huge. When you have this neuroinflammation, sets a whole cascading event. Accumulation of tau, we're familiar with CTE and some of the effects that we hear in the media about that, but accumulation of the toxins in the brain is essential to realize, and tau is one of those toxins. Hormone dysfunction. We're going to go over a little while about the hormone and some studies that showed over patients' life, particularly female patients at a young age, that can cause a huge disruption in their brain activity and their whole body functioning over someone's life. Psychological problems, psychological dysfunction, cervical spine issues, particularly we see a lot of times in trauma, sports injuries, motor vehicle collisions, the upper cervical ligaments when they get damaged cause proprioceptive problems and feedback to the brain that could cause a bunch of issues. So cervical spine dysfunction is a major secondary injury. Vestibular dysfunction, the brain-gut axis dysfunction. So the enteric nervous system, I think, is missed in a lot of cases with patients. This is essential to realize that our enteric nervous system is essential for recovery for patients with brain injury. It's often overlooked, but the brain-gut axis is really important to study and realize about. We're going to talk a little bit about that today as time allows. Demyelinization and oxidative stress, and then the secondary effects of disorders, such as a patient winds up having secondary effects like, say, seizures or stroke or other pathology. The secondary diseases become a whole disease process in itself and cause more secondary and even tertiary injuries. So a secondary injury, these are all injuries that the pathophysiology is established that cause in the brain after a brain injury, but it's essential to realize each process may feed off of each other and be cumulative. As I stated earlier, brain injury is complicated. There's a lot that goes on in the brain, even without injury, and pre-existing factors as well, and even post-trauma factors. And it's not as simple as just a broken bone and the patient gets better. The brain is very complicated. This is a great diagram that breaks into some of the things that could occur with a brain injury and even pre-existing factors. So mental health-wise, there could be depression, anxiety, PTSD, schizophrenia, autism, and other mental health issues that complicate brain injury. Also, particularly PTSD and anxiety and depression could be a secondary effect of brain injury because of the life events and things that have happened because of the brain injury. Brain health, neurodegenerative, stroke, epilepsy, functional disorders. If someone has these before, they have higher risk of brain injury. The same thing with brain injury. If you have patients who have previous brain injury, having another brain injury is going to make things even more difficult. And again, each patient, each brain injury is different. It's almost like a snowflake. Every patient who comes in has a unique circumstance with their past history, trauma event, and also post-injury follow-up care. But this is a great diagram that goes over some of the factors that relate to it. The social cognitive impairment, so social interaction, emotional problems, cognitive problems. Many times patients with a brain injury tend to isolate themselves, which is never good. Stress, sleep problems, lack of exercise, food choices. Also genetics, epigenetics. Sometimes trauma could turn on genes or turn on mutations. PRRS, CNV, the genes could be activated, but also there could be social determinations such as discrimination, such as social disparities, pollutants in the atmosphere. So you see some of these, particularly with discrimination, even with some things that have happened in sporting events or even prison systems. You see that the lack of recognizing TBI or mental health issues. And then you get down to the neurotransmitter level, the cellular stress, the biome, the inflammation that may be in the gut, and the whole brain modeling as far as brain injury is concerned, overloading the stress, the predictive coding, our expectations of brain injury. So there's a lot of things that go into a brain injury, the pre-existing factors, the pre-injury factors, the injury factors, and then the post-injury factors. It's important to realize that each patient comes in with a different uh, paradigm and a different aspect of brain injury, we have to look at the whole person, not just one aspect of brain injury. As I stated, there's also a large genetic component that we're finding now. So we're finding the genes, mutations, risk factors. We're finding a lot of different things that affect a patient's outcome, um, not just the brain injury itself, not just the primary injury. So there's many genetic factors that you could look for to be able to determine if someone has a high risk of having persistent symptoms after a brain injury. So genetics is also something that should be taken into consideration. Re-injury status. We see a lot of patients that have mental health issues or have brain injuries, but they're functional. And if you take someone who has one or two previous concussions or some mental health issues or previous problems, and you have another brain injury, that changes the whole dynamics of this new injury. So you could have someone that they have a brain injury, and if it was just an isolated event to one person who never had previous brain injury or previous mental health problems, their recovery is going to be completely different than someone who has maybe a previous effect of anxiety or ADHD. Traumatic brain injury to those could cause neurocognitive disorders, adjustment disorder, depression, and that sort of complicates the healing process, but also increases the compounding effect on injuries on the person. This is one of the papers I was talking about traumatic brain injury in women across their lifespan. And again, each individual person, but also there's a difference between male and female with brain injuries. And this is a great paper. I would encourage anyone to read about it. And we're going to dive a little bit deeper into some of the things we're going to see in this diagram. But it's complicated. And so it's really important to realize that there's a lot more going on than just what we think about with a brain injury. So first, let's talk about the TBI, the primary injury, or the mechanical insult. You could have vascular damage, meningeal damage, ischemia, neuroinflammation, um, inflammasome activization, blood-brain barrier breakdown, inflammation of the cells, exoactivity, reduced blood flow, intracranial pressure, edema, mitochondrial dysfunction, generation of ROS, axonal damage, neurodegeneration, stem cell depletion, and also activation of the astroglial cells. So the things that occur after that primary injury, and we went over a list of all of them, and you see it right here, is that those secondary changes then lead to the symptoms. And you see the symptoms of stress, hormone dysfunction, internalization disorders, neurodegenerative diseases, sleep disturbances, motor, sensory impairment, headaches, dizziness, emotional and social problems, cognitive dysfunction, and neuropathic pain. So these are the symptoms secondary to the secondary pathology occurring into the brain. But it's also important to look at the whole picture according to someone over their lifespan. And that, like I said, this paper is a great read, but it goes into, okay, it's a pediatric patient. Then they're going to have frequent falls, sex hormone changes, athletic lifestyle, addiction problems, oral contraceptives, pregnancy, stress, migraine, perimenopause, hormone therapy, fragility. So over someone's lifetime, some of these effects and even some of the secondary, even medications or treatments or secondary long-term problems because of these initial pathologies are important to get a big picture, realize over someone's lifetime that could cause widespread effects, not just something that's cognitive or we think of just an isolated event, but there's long-term defects that could occur over someone's lifetime because of this. This is a table I put together to get sort of a big picture view on what happens with a brain injury, like the 50,000-foot view looking down on a lifespan of some of the things that occur within the brain. And that first column we have traumatic brain injury or concussion. And typically it's an acute situation that we classify on the entry level as mild, moderate, and severe, but this is just a medical classification of systems, and we're going to talk about this in a little while, but it's generally acutely as mild, moderate, and severe. Then you have the primary injury, which can be the mechanical damage to the brain, such as a concussion, which is an electrical storm that occurs in the brain. And so there's an entire presentation I have on the pathophysiology of acute concussion. But basically, think of it like an electrical storm that occurs in the brain that causes a lot of cellular level changes and tissue changes in the brain. So you could have a concussion, you have diffuse axonal injury, you have brain hemorrhage, which typically we think about a brain injury, and that's why most people are saying classified as not having a brain injury because of the fact they say there's no bleed on CT scan, which we know that most patients don't have bleeds. Penetrating injuries, which again, we don't see too many of, but it is something where it's important to say this is a mechanical injury to the brain. Counter coop injuries, secondary impact injuries. So if someone is in that initial acute stage and has a secondary impact, it can be devastating for their brain. So secondary impact injuries are also important to consider. Brain contusions, acceleration, deceleration injuries to the brain. Blast and head strikes, something that actually hits and the outside of the brain but doesn't penetrate. And historically, and you're seeing a lot more emphasis on subclassification or subtypes of concussion based on symptoms. And this is a great thing to do after the initial classification, because initially you want to classify them, is there something concerning to say that they're going to die? After that, typically you're going to focus on, okay, what is the subtype of concussion to focus on symptom resolution? And this is very important because we do want to reduce symptoms, but we want to keep in mind we want to correct the function that's occurring in the brain too. And the subtypes are cognitive, ocular motor, headache or migraine, vestibular, anxiety, mood, and you have two associated subtypes such as cervical, sleep disturbances. And we discussed about the importance of the clinical recovery, which usually occurs in less than 3 months. The Brain Injury Association of America basically has set that window of time for symptom resolution, that the symptom resolution, if it's going to resolve within the first 3 months, then that is the TBI stage. After 3 months, they'll be considered the persistent post-concussive symptoms. Then we have the physiological recovery. So that is different than the clinical symptom recovery. The physiological recovery typically will occur within 7 to 30 days. And this is something, again, the acute concussion model, when you go over what's happening pathophysiology in the brain with acute concussions, you're going to see typically within 7 to 30 days, you're going to have physiological recovery. But the earlier you function on restoring physical functioning to the brain, the better the outcome will be for the patient. So, sure, the clinical symptom recovery is going to be 3 months by definition, but the physiological recovery is important to reduce flowing into that PPCS category. So the second category we look at, which is the green column, we're going to look are they symptomatic or asymptomatic? And this is something that could change over someone's presentation. So they could do different things to reduce the symptoms, but that doesn't mean that the things are going on perfectly in the brain, such as if they have, say, headaches or other problems that are taking medications for the symptoms. That doesn't necessarily mean that the brain is actually functioning well or going to be good long term. That's just sort of putting a band-aid over it. One thing I like to think about, sort of like your check engine light's on, and if you cover the check engine light, doesn't mean the engine's working well. That just means you're not paying attention to it. So it is important to focus on symptom management, but also realize the underlying pathology occurring in the brain can be very detrimental long term. So we have the secondary injury, and we discussed about that with the negative neuroplasticity, blood flow problems, glial dysfunction, mitochondrial dysfunction. So we went over all of those things. And typically, the persistent post-concussive symptoms is going to be classified after 3 months. And there's a recent publication put out by the Brain Injury Association basically talking about how these symptoms would have to be after 3 months, and then they're considered to fall into the category of PPCS. Now, the physiological effect can start hours or even days after the primary injury and progress over time. Then we flow into the third category, which is the category we want to stay away from as much as possible, is the neurodegenerative disorders. And that could be rapid, such as seizures. It can be progressive, which again, seizures can happen progressively over time as well. And it can be multi-system as well. So you could have other systems involved, such as the enteric nervous system, endocrine system. So with the neurodegenerative disorders, typically you'll see that the disease process will be evident either rapidly, progressively, or it can be multi-system. And this is the ternary injury. So you're going to see dementia and Alzheimer's, which is very well associated with traumatic brain injury, stroke, seizures, epilepsy, CTE, suicide, chronic pain, neurologic and psychological problems. Again, this is a feedback thing that, again, it's going to make things worse and just be cumulative over time. Motor disorders such as ALS and Parkinson's. You could have chronic pain and headaches, and many other diseases. It's important to realize that when they're in this category, that the traumatic brain injury is not an event or final outcome, but rather the beginning of a chronic process that may be multi-system and disease causative or accelerative. So even if someone has, say that they have the early stages of dementia and they have a brain injury, that could push them into having more accelerated brain injury. Brain injury is one of the leading cause of morbidity, disability, and mortality across all ages. That's important to repeat. Traumatic brain injury has become one of the leading causes of morbidity, disability, and mortality across all ages. Typically, in this stage, the clinical symptoms are managed. There's no expectation for any type of recovery from this clinical symptoms. It's more of a managed, not necessarily treated for resolution. And the physiological effects can take weeks, months, or even years to be evident. So again, this is a big picture sort of summary 50,000-foot view I put together to have sort of an idea of the flow of a patient from traumatic brain injury to PPCS to neurodegenerative disorders. This slide builds off the previous slide. And mild, moderate, or severe injuries are entry-level medical classifications. And yes, they are very important because if there's a bleed or something life-threatening, I mean, death is very common for people with traumatic brain injury in the moderate to severe category. But it is important to realize that these are entry-level medical classifications. And it is important to realize even mild traumatic brain injury is missed in many cases. A recent study at a hospital found between 50 to 60% of patients who enter into their ER get missed that they had mild traumatic brain injury. So a good diagnosis is the first step to a great treatment, and it's never the wrong time to make the right diagnosis. So even if a patient has traumatic brain injury, it's been 6 months, you really want to focus on what is the accurate diagnosis to get them the treatment they need. Obviously, the earlier the diagnosis is made, the better likely the outcome. But severe brain injuries are unconscious and unresponsive. Moderate brain injuries are typically non-functional. And mild brain injury is a functional injury to the brain. A mild brain injury is a severe disruption of life. In general, makes life more difficult, results in pain and suffering. Mild traumatic brain injuries are concussions, and they are serious. Healthcare providers may describe these injuries as mild, but they're usually not life-threatening. But a mild brain injury is only mild if it's not your brain. As we've discussed, this mild brain injury, the secondary effects can lead into secondary changes that can be very disruptive long term and cause neurodegenerative changes. The National Academy of Sciences, Engineering, and Medicine in 2022 put together this wonderful document, Traumatic Brain Injury, a Roadmap to Accelerating Progress. It is a wonderful peer-reviewed document that everyone should have and look into. It's just filled with great information about TBI and research. But I pulled out these quotes from the document because they're fit with what we're talking about today. Not only is the current classification of acute TBI as mild, moderate, or severe crude, but also promotes the bias that could limit care. Patients with mild traumatic brain injury often receive no follow-up care based on the assumption that spontaneous recovery will occur, despite growing realization that a subset of these patients will experience persistent symptoms and impairments after the mild traumatic brain injury. This is pretty powerful. Another statement they have, traumatic brain injury should not be treated as an isolated event, but as an evolving condition that may have long-term effects. Again, this is a great document, and this focuses on the need for not just acute TBI care, but also the progressive nature of it and into the PPCS components and the neurodegenerative diseases components. So it's important to focus on not just the symptoms, but also on the pathophysiological process underlying. We went over this earlier, but there are 7 main types of mechanical insult into the brain. And you have concussions, which concussions are an electrical storm that occurs in the brain and a disruption of the normal function. You have the brain contusions, brain hemorrhages, which is typically when we think about a brain injury, we think about a bleed, but that doesn't happen in many cases. Diffuse axonal injuries, counter-coop injuries, you have penetrating brain injuries, and second impact syndrome. So if in a short period of time, if someone has a repeat concussion, that could be very devastating to the brain. As we discussed earlier, there's many causes of persistent post-concussive symptoms. But the five main causes you could think about in a clinical setting would be vestibular problems, blood flow problems, psychological problems, cervical problems, metabolic, inflammatory, or hormonal problems. So again, psychological, blood flow dysregulation, vestibular, cervical, metabolic, inflammatory, or hormonal. As we pointed out earlier, the secondary effects of TBI can include loss of balance or coordination, cervical spine dysfunction, nausea, vomiting, sleep disturbances, cognitive decline, post-traumatic headaches, speech disorders such as slurred speech, mobility issues, vision and hearing changes, social and emotional problems, deconditioning, functional neurological disorders, autonomic dysregulation, endocrine dysfunction, seizure, stroke, anxiety, PTSD, and mood disorders. These secondary effects also have negative effects on the body long term as well. And again, they deal into the pathophysiology of persistent post-concussive symptoms because these secondary problems, such as sleep dysregulation or sleep problems, can have adverse effects. So the sleep deprivation can lead to memory issues, concentration issues, mood changes, accidents, weakness in immunity, poor balance, risk of heart disease, low sex drive, weight gain, diabetes, and high blood pressure. So sleep is linked to every biological function in the body, and it's really important for sleep. The bottom line is that patients who don't get sleep, and it could be secondary to the brain injury, have a cascading effect into other health issues. As we pointed out earlier, the brain is just amazing how it communicates and has a quadrillion interactions with other parts of the brain. So it's really mind blowing to think about what the brain actually does. Um, but a brain injury can also cause problems with functional neurological disorders. So it's a condition that affects how the brain sends and receives information, and it interferes with the normal pathway. So basically, it scrambles the messages or just sends messages in a different way. And again, with neuroplasticity, this could be an effect too. But it's important to realize that also, if you change the lines, the way the brain is actually wired, or change the function of the brain, how it sends and receives messages, that causes a cascade of many secondary effects. Brain injuries are scary. And there's different things that could cause mental health issues in patients. You could have one, the traumatic event itself. You could have patients afraid about a brain injury and the symptoms they're experiencing, but also things could happen in the brain, rewiring or different reactions that occur in the brain that could actually cause mental health issues as well. Within each patient, we also have to account for different mental health issues. There is a lot of overlap between mental health issues and traumatic brain injury symptoms. PTSD, anxiety, and TBI have a lot of overlap. But also with patients, it's normal or common to have patients catastrophize. And rumination is very common where they can't think of anything other than the brain injury. They can't stop thinking about the event or the brain injury. They Google on a consistent basis about brain injury. They talk about brain injury. And the more they think about it, it's difficult to heal. Rumination often occurs and it's different for each person. It could slow down the processing speed. It could also cause resources in the brain to be focused on worry, anger, catastrophizing, and that could also lead to disorders such as anxiety, hypervigilance, and just continually focusing on the injury itself, which could be counterproductive. Helplessness is a very common problem as well. Even preconceived notions about brain injury, about how they're going to have this problem for the rest of their life. Nothing I can do will help myself get better. There's nothing that will help. The doctors have tried everything. And helplessness is one of the many emotions that could be experienced after brain injury, along with anger, demoralization, or hopelessness. The parts of the brain involved in motivation may be also affected by the actual brain injury itself. So depression, hopelessness, or the way that they look in the future is very common to have a feeling of hopelessness or just given up. And these are also things that are very real for patients. So it's important to account for them in therapy sessions and getting mental health care. Fear, anxiety. They're afraid to do things, um, or just fear I'm not going to get better. Fear avoidance is a very common thing. Brain damage often causes damage to parts of the brain that regulate emotions or hormones. There's fear about the recovery, concerns about the recovery of uncertainty of the future, lifestyle or relationship changes. And many of the brain injury patients I see, they've gotten divorced, lost their jobs. And so it is very serious because there's a lot of life altering events that occur that also can impede healing or cause continued feedback mechanisms within the dysfunction of the brain. The stressful situations can cause things to get worse as well, being in crowds, being rushed, um, different things that could occur in the brain that normally would process well, but don't process when you have a brain injury. And these all lead to sometimes co-current uh, post-traumatic stress syndrome, anxiety, or mental health issues. And those are all things that sometimes the mental health issues can be separate and sometimes they can be part of the brain injury. But it is important to realize this is a fact so that way the patient can get the best proper care. As we go over the next few slides, it's important to realize that although in diagrams things may seem simple, behind the scenes there are a lot of enzymatic processes or cycles that occur that are a lot more complicated. And so some of these things we will go in detail with, and other things we're going to basically just leave as the core concepts. In the next series of slides, we will be going over many flowcharts, diagrams, and pictures to help some of the main concepts of persistent post-concussive symptoms. So again, with a brain injury, we have the acute changes on a cellular level, molecular level, and clinical level, and they could develop into chronic changes. But if we have a single traumatic brain injury versus repetitive brain injury, we could see that there's actually differences because of the repeated brain injury that occur over time. We have a primary insult to the brain with primary damage and mechanical damage, and the secondary insult, which is the pathophysiological process or delayed and non-mechanical processes. Phase one would be impaired blood flow, metabolic imbalance, membrane permeability, and tissue damage. That could lead to vasogenic edema, cytotoxic events, inflammation, blood-brain barrier breakdown, and that leads into phase two, which is the depolarization, intercellular breakdown, apoptosis, necrosis, free radical generation, and release of excitatory neurotransmitters. Over time, this will lead to cell death. This is a great picture outlining the primary injury and secondary injury. So the primary injury would be the shearing, compressing, and tearing of tissue and blood vessels. The secondary injury would be the cognitive dysfunctions, dendritic and synaptic degeneration, blood-brain barrier disruption, inflammation, oxidative stress, apoptosis, and cell death. This was a study in the Journal of Neurotrauma that used biomarkers to show each pathological process, which is really interesting. Shows the injury, necrosis, axonal injury, glial injury, cellular death, demyelination, microglial neuroinflammation, and chronic neurodegenerative systemic responses. So it's a great paper. I would highly recommend reading over, but they use biomarkers to help show the tissue damage and progressive nature of the demyelination and chronic inflammation that occurs in the brain after a brain injury. Again, here's another diagram that goes into the initial injury stage, which is focal, diffuse, rotational, penetrating, or shearing forces. The primary insult would be vascular, diffuse axonal injury, or cellular damage. The secondary, which could occur hours to days afterwards, are ischemia, swelling, edema, inflammation, or cell dysfunction. Within weeks to months, we would see neuroplastic changes and cell death. Within months to years, we'd see more neuroplastic changes, neurological compromise, behavioral compromise, and then over time, we would also see pituitary deficiencies or endocrine problems. So they say repetition is the mother of all learning. And this is the last big picture slide we have concerning brain injury, showing the primary damage that can happen within seconds to minutes after the TBI, to the secondary damage that could happen hours to days afterwards, and then months to years, the neurodegenerative effects. So just like the previous slide, this shows the primary damage, what happens on a cellular and tissue level, the secondary damage, and then the neurodegenerative aspect of it. So the initial acute stage, the persistent post-concussive stage, and then eventually the neurodegenerative stage. We have about 10 more minutes, and we're going to dive deeper into the pathophysiology of persistent post-concussive symptoms. And we're going to start off with neuroplasticity. So neuroplasticity after a brain injury occurs in three phases. First 48 hours, you have the initial damage caused by cell death and loss of cortical pathways. The brain uses secondary pathways to maintain function, and cortical inhibitory pathways are decreased for 1 to 2 days. This may recruit or unmask new neural networks. In the following weeks, support cells are recruited and cortical pathways shift from inhibitory to excitatory. In weeks to months, the brain continues to remodel itself through axonal sprouting and reorganization around the damaged area. However, the initial decline in brain structure and function caused by the TBI can also lead to negative neuroplasticity. This can happen with the loss of reduced patient motivation or inability to participate in cognitive demanding activities, which leads to disuse and negative learning. This can cause a downward spiral of negative neuroplastic changes that lead to neurodegeneration. Neuroplasticity is a pathology that really needs to be dealt with brain injury, but also is a path to rehabilitation. So neuroplasticity, I think, is underutilized in a lot of patients who have brain injury. This is a great picture showing what happens after a brain injury. So you have a healthy condition or healthy nerves. You see where there's connections. You have a nerve injury or brain injury where the cells are no longer there. And then to have proper recovery, you have to make those connections. If those connections are never reconnected, that causes problems. Now we're going to go a little bit more in detail of the glial cells. We talked about these earlier, but they are essential and I think a big part of brain injury and the persistent symptoms. So we have the central nervous system and peripheral nervous system. We have the astrocytes, which help to maintain the blood barrier, controlling the synapses, regulation, and metabolic support for the neurons. The epidermal cells, which line the spinal cord, ventricles of the brain, involving in production of cerebral spinal fluid. Oligodendrocytes, they help to provide structural framework of the neurons by providing the myelin sheaths. Microglial cells, they are the brain's immune cells, removing dead cells and pathogens by phagocytosis. In the peripheral nervous system, we have the satellite cells and Schwann cells, and they do similar functions. It's important that oligodendrocytes basically have one oligodendrocyte for every neuron. The Schwann cells can actually have up to 100 nerves that they myelinate. So it shows the importance of the oligodendrocytes in the brain for myelinating the nerves, so that way it keeps good conductivity. When these cells get inhibited or break down or have dysfunction, long term there could be some significant effects, some inflammatory effects, as well as some degenerative effects. I love this example about the oligodendrocytes or the Schwann cells that they coat the myelin sheath around the nerve to help with conductivity. Just like a power line or a speaker wire, if there's no coating around it to help with conductivity, you lose loss of signal, loss of speed, and that could definitely lead to neurodegenerative changes. Senescent cells, or zombie cells, are cells that are damaged and do not die off when they should. They can accumulate in the brain at sites age-related pathologies. Senescence can contribute to brain aging through three mechanisms: synaptic dysfunction, neuroinflammation, and impaired neurogenesis. There are various mechanisms for these zombie cells. It could be a single moderate to severe TBI, repetitive mild traumatic brain injury, and these could cause oxidative stress, mechanical stress, genetic changes, and inflammation. And that leads to the process of making the cells inactive, in a sense, a zombie cell. I really like this picture showing the effects of these zombie cells and what happens when sensitive cells become activated. So for the astrocytes, you wind up having reduced support for the neuron. The microglial cells, you have increased inflammation, neurodegeneration. Oligodendrocytes, you have decrease in myelination around the axons. The neurostem, you have decreased neurogenesis. The neuron, you have decreased function. And the epithelial, you have a decrease or disruption of the blood-brain barrier. I love this because it summarizes it very well. Blood flow dysregulation is also a big part of brain injury. So there could either be too much blood to an area, too little blood, but the regulation is extremely important because if you have too little blood, you could have cell death. Too much blood could cause intracranial pressure, hyperfusion. And so the regulation of the blood is very, very important. The blood-brain barrier is extremely important. When you have a breakdown in the blood-brain barrier, you have a secondary effect and you have inflammatory agents that come in. You have other issues with the blood-brain barrier that causes neuroinflammation and demyelination. Mitochondrial dysfunction is huge on a cellular level when it comes to brain injury, and recognizing that helps to recognize that treatments such as laser, exercise, lifestyle medicine, and other therapies can help the mitochondrial function better, ultimately helping the brain function better. Secondary disorders like seizures can cause continued progressive problems within the brain. This is a nice flow of what happens in the pathophysiology of seizures. And it's important to recognize that as seizures develop over time, they cause continued brain damage. So it's the damage on a cellular tissue level that over time lead to the seizures, and these seizures then over time lead to other pathology in the brain. There is a connection between our brain and the enteric nervous system, and studies have found that brain injury affects the cells in the intestinal lining and in the intestines and cause inflammation and breakdown, and it is a feedback cycle as well. The gut-brain axis is becoming a lot more prominent when it comes to studies about brain injury, and there's a lot of research showing the effects of the brain injury on the enteric nervous system. And again, this is something I just wanted to bring to your attention, but also later down the road, you'll see a lot more studies about this. Another great chart that illustrates the pathophysiology between the brain and the gut. Studies have shown that there are quite a few endocrine changes that occur after brain injury. Diabetes, metabolic disorder, endocrine problems, hypothalamic, pituitary problems, growth hormone dysfunction. It is very common to see in the literature that after brain injury could be months or years down the road, there is an increased risk of having endocrine problems. Cervical instability is very common with brain injury, particularly in acceleration, deceleration injuries. So you'll see a lot of overlapping symptoms between the cervical instability or cervical pathology and the brain injury. So just want to make you aware of this. There's a lot of research showing this as well. I'm going through these real quick as we're running out of time, but this is a great diagram of what happens with the chronic inflammation and accumulation of toxins within the brain that later on lead to neurodegeneration. We know that there are many mechanisms for neurodegeneration, and it's important to have patients take an active role. There could be metabolic problems, genetic problems, neurovascular problems, neuroinflammation, but also it's really important to have them take care of the things they can control as far as lifestyle is concerned, and to get them to be an active participant in their health, not just a passive bystander. Over time, as we go from the acute stage to the persistent post-concussive stage to the neurodegenerative stage, then we could see some of these effects evident on advanced imaging such as DTI, such as traditional MRI, functional MRI, ASL, and MRS. So these are all things that over time that you'll start seeing the long-term effects. And it is interesting because it may take months or even years, but then on follow-up scans, you could actually see some of the long-term effects of the neurodegenerative diseases. Thank you for watching my presentation on the pathophysiology of persistent post-concussive symptoms. I know it was a lot of information in a short period of time, but I hope you found it useful. Have a great day. Thank you.